Hi, and welcome back to the Integrative Women's Health Podcast. I'm your host, Dr. Jessica Drummond, founder and CEO of the Integrative Women's Health Institute. And today, I have a pretty hot topic to cover with you. We're going to talk about how to help your clients or yourself navigate perimenopause and menopause if you have endometriosis or a similar chronic health condition. We're going to get into other chronic health conditions. We're really going to mostly focus on the research around endometriosis today. We're going to do a deep dive into the research. So you are going to see me reading my notes a bit on this episode because I wanted to share with you very cutting edge perspective on navigating perimenopause and menopause with endometriosis, especially given some of the myths in the endometriosis community. You or your clients might be confused about some of the core challenges with navigating perimenopause and menopause in general. And then if you have endometriosis, what does that mean for you? So is taking medical hormone therapy or hormone replacement therapy dangerous for you? Is it going to exacerbate your endometriosis, as there's this consideration in the community of endometriosis that endometriosis can be, and this is true, it can be an estrogen-driven disease, though not always. What about the weight gain of perimenopause and menopause? What about the metabolic issues, the cardiovascular issues? Is this exacerbated by endometriosis? Is it common for your other comorbidities like autoimmune diseases, histamine issues, bladder or sexual pain syndromes, vulvovaginal pain issues, changes in the uterine, vulvovaginal, or bladder microbiome? What about your hypermobility, your dysautonomia? Are these things going to get worse through perimenopause and menopause? So during perimenopause and menopause, women with endometriosis have special considerations they have to think about to take care of their health. So increasingly, there's two different pushes going on in the conversation around perimenopause and menopause. One is everyone gets hormones, like add that medical hormone therapy, the estrogen replacement, progesterone replacement, sometimes testosterone replacement. As soon as someone enters perimenopause, there's a relatively one-size-fits-all prescription. It's covered by insurance, ideally. And it's just like, as soon as you start feeling any kind of perimenopausal or menopausal symptoms, you should be given this sort of standard prescription of hormones. And we're seeing that in countries with socialized medicine and in the United States, which does not have socialized healthcare at all in our insurance system. But there's also this other conversation or this other perspective of people in sort of the integrative and holistic world saying, absolutely no hormones. What's going on here? Women have been going through menopause and perimenopause for hundreds of, thousands of years without needing these artificial hormones. What about the cancer risk? Forget it. I'm not just, taking hormones just because I'm a certain age and have these symptoms. Well, and I think, as always, I mean, you probably at this point on this podcast have heard me say this 100 times, if not once. There is a nuanced conversation to be had, which gets even more complicated for those of us living with complex chronic illnesses such as endometriosis, hitting ages 35, 40, 45, where we're also beginning the perimenopause to menopause transition. And by the way, continuing into our 50s and even 60s or beyond if this is never addressed. So just because someone has completed the menopausal transition, and I saw a gynecologist recently who said to me, these menopausal symptoms, well, they just go away in a year anyway, it'll soon be over. That is not true. That is just not true. I mean, raise your hand if you're listening to this right now and you're over 50 and you might even be over 60 and you still have hot flashes, weight loss resistance, challenges with your cholesterol level, your blood sugar regulation, your bone density. Like, this does not just snap our fingers and get better once someone is a year past having their last period or even a couple of years after that. This doesn't go away on its own. So women from 35 to 65 and beyond are being really dismissed and not given nuanced, complete, holistic options for navigating the perimenopause to menopause transition and beyond, especially if they have chronic conditions like endometriosis. So it's not one or the other. There's not one prescription for hormone medley that is going to solve all of your symptoms and your root underlying problems. And many people navigating perimenopause and menopause, even if they have estrogen irritated endometriosis, sometimes do benefit more than is problematic with adding low dose hormonal medical hormone therapy. So let's talk about how you can be asking your providers to start thinking in this more nuanced way. And hopefully, for all of our providers, our health and wellness, women's health and wellness professionals in this community, your eyes are going to be open to starting to think about, okay, how can I better help my clients with endometriosis or other complex conditions navigate perimenopause and menopause? So, first of all, let's talk about some of the myths in this community. One, it is a myth that endometriosis can't be diagnosed in perimenopause or menopause. That, you either have it when you're in your teens, early 20s, when you're, navigating through fertility, or you don't. And that's not true. And increasingly, I even believe that perimenopause can be the trigger that incites someone to actually have endometriosis who maybe had the genetic vulnerability, but did not actually express endometriosis until they're in their later 40s or beyond. And we'll get to the research on that in a moment. It's also a myth that endometriosis is quote unquote cured by menopause. That is absolutely not true. Now let's dive a little deeper into some of these myths. In 2019, a study was published in the journal Diseases, where researchers in Greece at the University of Crete and in the United States at Yale University School of Medicine looked at endometriosis in perimenopause and menopause. So this was done across those two research sites. In the perimenopausal group, so this was women ages 45 to 54 who were not yet fully through the menopausal transition. There were 184 patients that were diagnosed with endometriosis, 16.7%. So this is what brings me to believe that one, either a woman's endometriosis was missed. She may have had early signals. So for example, just today I was talking to a client of mine who's like, I never felt significant symptoms of endometriosis until I was in my 40s and I was starting through the perimenopause transition. But I do remember as a teenager having some painful periods, having to kind of learn to manage that. It wasn't severe, life altering, but it was noticeable. So there's two things that could be happening there. It could be that someone has had relatively lower symptoms or less expressed endometriosis in their younger years, and then it just gets worse, or the symptoms become more noticeable by the trigger of perimenopause, menopause, or actually they had that predisposition, but it wasn't expressed at all until the trigger of perimenopause and menopause. So that 16.7% diagnosis of endometriosis in perimenopause could just be a delayed diagnosis, or it could be a new diagnosis because of the trigger of the hormone shifts of perimenopause and menopause, and potentially the metabolic shifts of perimenopause and menopause, which we'll get into shortly. And then again, in the postmenopausal group, ages 55 to 80, 46 or 4.2% of the women were diagnosed with endometriosis. Again, could be that menopause or some postmenopausal trigger could have actually triggered the expression of the endometriosis, or it could be that the symptoms were missed and the diagnosis was significantly delayed. So in that perimenopausal time frame, the average age of diagnosis was 49, and it was 61 in the postmenopause group. Advanced endometriosis was actually more aggressive in the perimenopausal group. In the same group, they also noticed in that perimenopausal group higher left-sided predisposition of the endometriosis in comparison with the right side. endometrioma was the most common gynecological condition among patients with perimenopausal endometriosis in relation to the postmenopausal group. Additionally, they also found more uterine fibroids in the perimenopausal group than in the postmenopausal group, which does make more sense because uterine fibroids generally are a more estrogenic condition. In contrast, adenomyosis was found in a higher percentage of postmenopausal cases, and they also found more women with both endometriosis and dry eye in the postmenopausal condition, which is interesting. So the research has concluded that post or peri and postmenopausal endometriosis is a really important and under considered and looked for condition. Clinicians do need to be aware that there's a correlation between endometriosis and endometriosis associated ovarian cancer in perimenopause and postmenopause. In a study that was published in 2014 in the journal Biomed Research International, researchers considered factors in women with endometriosis premenopausally and how they fared from a health standpoint then postmenopausally. So this is where that early intervention of our entire integrative suite of tools, nutrition and lifestyle and sleep and supplementation and stress management, and in some cases, medications and skilled excision surgery, how, if someone took better care of themselves premenopausally, was the endometriosis expressed postmenopausally. So for women who were aware that they had endometriosis prior to perimenopause, when they improved their fitness, their social connections, and their mental health care, that dramatically improved their postmenopausal symptoms of endometriosis. So in that premenopausal timeframe, they're exercising more, their mental health care is more supported, and they had good, strong social connections, which I do see as being a problem for women in their 20s, 30s, 40s with endometriosis because the pain can be so debilitating and unpredictable that it makes it hard to maintain social connections. So the results of this study strongly suggested that physical fitness and freedom from physical restrictions, a good social environment, and psychological care in both the premenopausal and postmenopausal periods led to marked improvements in the postmenopausal period with regards to the actual physical symptoms of endometriosis, things like pain, things like dyspareunia, things like sexual pain and sexual satisfaction. So for our patients in their 30s and 40s, as they enter perimenopause, this is a really important time to emphasize their capacity for movement, making sure exercise at whatever level is appropriate for them at the moment and improving it as tolerated is a really vital time to get that optimized. Also optimizing their web of support, their social connections, their mental health support. Health coaching is invaluable in the 30s and 40s for women with perimenopause, because then they can transition into menopause having established these habits that will absolutely reduce their symptomatology. So those are some of the myths. And let's talk a little bit about the hormonal milieu of endometriosis. So, when I first started getting involved in this diagnosis and this diagnosis community and doing, physical therapy, pelvic physical therapy to help my clients with endometriosis, the standard knowledge was that endometriotic lesions are fed by estrogen and that the endometriotic lesions themselves create their own estrogen. But we actually learned in 2018, so that 2018 study was published in the Journal of Gynecological Endocrinology by a group of Belgian researchers. Our thoughts collectively in the clinical world of endometriosis shifted from endometriosis being an estrogen-driven disease. That's been thrown out the window. This specific study was entitled Heterogeneity of Estrogen Receptor Alpha and Progesterone Receptor Distribution in lesions of deep infiltrating endometriosis. So they did only study deep infiltrating endometriosis of untreated women or during exposure to various hormonal treatments. What did they find? Well, first of all, it's been known for decades now that endometriosis responds to hormonal therapy, but inconsistently. We also learned that mutations in cancer driver genes have been identified in a fracture of the ectopic endometrial epithelial cells, suggesting a functional heterogeneity of these lesions. These lesions are not all exactly the same. Thus, this study looked to evaluate that functional and phenotypic heterogeneity in these deep infiltrating endometriosis cells by measuring the expression of estrogen receptor alpha and progesterone receptors in the deep infiltrating endometriosis of untreated women or those under various treatments. They examined the estrogen and progesterone receptors in these lesions, and they observed a high variability in the same gland among distinct glands in the same woman and across different women, receiving some of the same treatments. So within the same person, even within the same lesion, but certainly across different lesions in the same person, some had upregulation of estrogen alpha receptors, some had upregulation of progesterone receptors, some had both, and some had neither. So clearly, there's not just this sort of one size fits all estrogen suppressive treatment or increasing progesterone. That's a kind of a new thing I'm hearing out of the more integrative and holistic community, that women with endometriosis just need progesterone creams. Absolutely not. Sometimes that can make the situation worse and can actually contribute to certain cardiovascular risks that are unique to women. So we have to be really careful of any kind of sort of one size fits all approach to hormonal support for women with endometriosis. And this is, this heterogeneity in the estrogen and progesterone receptors could be part of the explanation about why hormonal treatments for endometriosis have never been a good, consistent cure or even symptom management. So when I learned about this study back in 2018, it really changed my focus, even from an integrative and nutrition standpoint, on endometriosis. So we used to avoid like the plague, things like maca, which can support better, healthier, more robust estrogen levels, or we would really promote estrogen metabolism to be revved up, and by making sure estrogen metabolism was optimized in the liver. I still think that's important because women do have estrogen, and we may want to support estrogen in the perimenopause to postmenopause period. We'll talk about that in a second. We do want to make sure it's metabolized, but not we don't want to push a quote unquote estrogen detox necessarily, because women of all ages, but certainly women in perimenopause and menopause. So if you are 35, 40 and older, you probably have felt in your body the changes, as the metabolic changes and the endocrine changes as estrogen levels decline inconsistently, by the way, for a period of 10 to 15 years in perimenopause. So as that estrogen declines and it kind of pops up and down, as progesterone varies and slowly declines over that period of perimenopause, certainly symptoms increase. Sleep problems, blood sugar regulation becomes more difficult. Cardiovascular health risks increase dramatically, really, really quickly post-menopause for women. Brain fog, brain health, neuroinflammation. So women entering perimenopause and menopause just have to be so much more dialed in terms of their metabolic health because of the changes in hormones. So when I have a client with endometriosis, let's say she's in her 20s and 30s, I'm not focusing on estrogen suppression or estrogen detox, quote unquote detox. because women of these ages, to optimize their fertility, their brain health, their cardiovascular health, their bone health, their ability to build musculature, need healthy, robust hormone levels beyond anything about their endometriosis. And this is really how I think we need to be thinking about hormonal health in the perimenopause menopause transition. In different women, adding hormonal therapies could impact their endometriosis symptoms. So we have to be really mindful of that. But we don't want to throw the baby out with the bathwater. It's not like absolutely no low dose transdermal estrogen for someone with endometriosis. To me, that makes no sense at all because of all the other reasons that these women need estrogen support for cardiovascular health, for brain health, for dementia risk. I mean, I could go on and on. So let's move on to part 3. How can we help women with endometriosis to now better navigate perimenopause and menopause? So this is what we do in our practice. And stay tuned. This summer, we're going to be launching a group program. So get ready for that. And a more targeted program where we're working on now having the capacity to deliver those prescriptive services as well for hormones and some other tools that we're going to talk about in a minute. So navigating perimenopause and menopause with a complex chronic illness like endometriosis, like autoimmune disease, like post-viral syndrome, like MCAS is tricky. And that is what we specialize in. And we do it through a 7-step protocol. So first of all, no matter what's going on from a chronic disease or even a chronic transition or a transition state, we have to focus as practitioners for our clients on nervous system regulation. People cannot heal in a chronic fight or flight state. And that can be ruminating thoughts, that can be chronic anxiety, that can be a chronic freeze state, which is kind of the inability to get going, a sense of doom all the time. Like you might be sitting on your couch, but you're not relaxed. Being in a relaxed state of, as I say in polyvagal theory, calm aliveness, true rest and digest, takes focused practices on a day in, day out level. Things like mindfulness meditation, slow flow yoga, breath work, spending more time in nature, laughing with friends, playing music, making or observing art, connecting with people you love or pets. We've really lost a lot of that important nervous system nourishment, which is foundational to helping people with chronic illnesses navigate through perimenopause and menopause, because these hormone shifts make that nervous system vulnerability even more pronounced. So we absolutely have to start there. The more that the woman's system is in a calm, relaxed, focused, peaceful, attentive state, joyful state, pleasurable state, the less irritated the immune system will be chronically, because we know endometriosis is this chronic state of, it produces and it promotes this chronic state of inflammation, oxidative stress, elevated levels of localized lactic acid. This is inflammatory. And the nervous system, if it's in a fight or flight or freeze state, will promote and enhance the immune system to do more of that, which is what we don't want. We want to help the nervous system settle the immune system from being overreactive to anything, including the endometriosis or other chronic conditions that exist within that person's body. Then we have to move to step 2 of our protocol, which is making sure that we're super clear about your client's vision. What does health mean to them? What are their goals? What is so important to her specifically? Does she want to be a very present parent for her teenagers in this transition for everyone? Does she want to be able to hike crazy trails when she's 70 or 80 or 90? Does she want to be able to have a child at 45? Does she want to be an energetic mom? Does she want to get a big promotion at work? Does she want to be able to do a lot of international travel? We have to be very clear about our client's goal so that we can help prioritize the pace and the prioritization of therapeutic strategies. So it's really important to be clearly defining for yourself, if this is you, a person with endometriosis or other chronic disease navigating perimenopause and menopause, or if you are the practitioner working with her. Then in steps 3 and 4, we begin to collect data and use all the tools slowly but surely. And there are hundreds of them. I'm not going to get into all of them on this podcast, but it's very important to understand that there are lots of changes in this time frame for people with endometriosis that are unique. So what does this client's estrogen metabolism look like, right? Have you done a Dutch test? Do we know, is she pooping, right? Is she able to metabolize her estrogen? Is she constipated? Or how's her liver function? And so we can utilize testing, things like Dutch testing, to look at the liver pathway of metabolism of the estrogen. What are her inflammatory markers? Has she utilized liver function tests or things like the hepatic detox profile from doctor's data? We have access to this functional testing. It's direct to consumer, and it's really valuable for women to understand, are their detoxification, their normal, healthy detoxification pathways functioning optimally before we add more hormones to this situation? And what are her hormone levels? So, working with skilled practitioners like our team who can do that prescriptive analysis of serum hormone levels or urine hormone levels, whatever makes most sense for that client. Then, is she experiencing any symptoms of low hormone levels or high hormone levels or inconsistent hormone levels if she's in perimenopause? Low libido, vaginal dryness. What about more systemic issues like brain fog or joint pain? It's not just the reproductive system, it's not just the pelvic floor and urogenital system that is impacted. Is she experiencing symptoms of low progesterone, independent of her endometriosis? Things like poor sleep, insomnia, depression, bloating, headaches. So she could have endometriosis contributing to any of those, and or low progesterone. Is she experiencing symptoms of low testosterone, independent of her endometriosis? What is her personal cancer risk? So we do know that endometriosis can increase cancer risk. What about family history of breast cancer? Does she have high risk factors for breast cancer that could be related to her genetics or her family history? We do know that endometriosis leads to a 2 to 3 times increase in ovarian cancer, especially for more rare ovarian cancers. So how can this cancer risk be mitigated even utilizing some of these treatments? In a meta-analysis published in 2022, it was found that endometriosis can increase the risk of endometrial cancer and breast cancer. But in a 2024 population study, patients with endometriosis were found to have higher risks for ovarian and endometrial cancer, no significant risk for cervical cancer. Plus, this group of researchers observed a reduced risk of breast cancer with endometriosis on a population-based level. So this is really important. There's not just a one size fits all, which I think is actually calming to the nervous system of people with endometriosis, because it's not just automatically this elevated risk. There's so much we can do to mitigate the risk. So the cancer data is mixed and needs to be individually assessed using things like cancer markers like CA125 or the Gallery cancer screening for early detection, blood markers of many female cancers, including breast, cervical, ovarian, and uterine cancers. And then don't forget that the digestive, immune, and nervous systems are intricately connected with the endocrine system. This is where things start to get interesting and why it's different for people with complex chronic illness to navigate perimenopause and menopause than someone who isn't dealing with that. Because endometriosis is a chronic inflammatory condition with autoimmune characteristics, and for many people with endometriosis, there is an impact to digestive function and gut, uterine, bladder, and vulvovaginal microbiome, and more, maybe even potentially influenced by the penile microbiome of someone's male partner. Thus, before we even address the hormone shifts of perimenopause and menopause, or at least we want to be doing this concurrently, it's essential to optimize the functioning of the digestive system, of the gut microbiome, of the immune system. So this means that anti-inflammatory lifestyle, not just nutrition, lifestyle, sleep, nature, social connections, pleasure, joy, all of it is sometimes way more important than exactly what someone eats. That anti-inflammatory lifestyle, looking at lowering environmental toxin load. We live in an environment where it's just contaminated. How can we lower that load? And then considering triggers that can happen in or around the perimenopause and menopause period, such as viruses, bacterial infections, vaccine injuries, other major emotional triggers such as a divorce or other significant life stressors, a car accident, a surgery, could be anything that triggers the straw that broke the camel's back among, this constellation of inflammatory lifestyle, inflammatory food, heavy toxin load, heavy stress load, heavy infectious load over time. Someone might have gotten Epstein-Barr when they were 16 in high school, and now it's reactivated because in perimenopause they were exposed to Lyme, or they had quiet Lyme that they got in their 30s, never knew about it. It's been hiding in their, microbes in their body and biofilms potentially. We'll get into biofilms in a second. But then, they got COVID when they were 42. This is a spiral that can build over someone's lifetime, especially in the underlying context of also having the genetic vulnerability of endometriosis, whether or not that disease has been expressed before perimenopause. So we have a whole suite of tools, from nutrition to sleep to movement to supplementation, pre and probiotics, mental health support, movement, exercise, fitness, coaching, and so much more. So this is why our approach to perimenopause and menopause for people with endometriosis is so unique. Very rarely does a practitioner have the time to dig into all of this, but it can't be overlooked and just masked with, a kind of short-term therapeutic for perimenopause and menopause. But once all of these factors are addressed, supported, and these lifestyle changes are implemented transformatively, slowly over months and years, but then sticking there for the long term, then the supplemental medical hormone therapy dosing can become simpler and smaller. Not so much hormone support is even needed. And some may not even need supplemental hormones at all. They might do fine with simpler tools like peptide bioregulators or evidence-based MACA, again, keeping in mind individual cancer risks associated with even these tools. So uniquely, there are metabolic impacts of endometriosis that can worsen the symptoms of perimenopause and menopause, which we have these tools for, and we don't have to just, slap on a one-size-fits-all protocol. These metabolic symptoms range from weight loss resistance and hot flashes to cardiovascular risks, neuroinflammation, brain fog, dementia, and sleep issues, which is huge. It's probably the number one thing we hear people complain about, and rightly so. I mean, I'm obsessed with good sleep. So let's talk about the new research that's giving us even more information and insights into these metabolic risks of endometriosis, specifically in the context of perimenopause and menopause. So in a study published in 2022 in the International Journal of Molecular Sciences, researchers evaluated the levels of 10 energy metabolism factors. This study is so amazing, is so important because they looked at C-peptide, ghrelin, which is that hunger hormone, GIP, which we're going to be hearing more and more about it. Those peptides are now being looked at in the same way that we're looking at GLP-1 agonists, otherwise known as Ozempic, Wegovy, all of these brand names. But so this study looked at C-peptide, ghrelin, GIP, GLP-1, glucagon, insulin, leptin, PAI1, or otherwise known as SERPINE1. We'll get back to that. Resistin and visfatin. And they looked also to determine the expression of the DLP-1 receptors, CD10, CD26 proteases, and other pro-inflammatory markers, looking at the macrophages in the peritoneal fluid, so that fluid all around the abdomen and pelvis, in patients with endometriosis. So they're looking at these metabolic and inflammatory markers in a way that hasn't been studied before. This is a very new study from just last year. The study included 54 women with endometriosis and a control group of 30 women with uterine myoma, but no signs of endometriosis. It was found that women with endometriosis, the concentrations of ghrelin, which is the hunger hormone, GLP-1, which is that peptide that you're hearing all about in these weight loss drugs, glucagon, and visfatin in peritoneal fluid were all reduced. At the same time, there was a noted increase in the CD10 protease expression by the peritoneal macrophages, so more inflammation. These results indicate that these decreases in the various metabolic factors that they were looking at may contribute directly to endometriosis development through their impact on the expression of pro-inflammatory markers of peritoneal fluid macrophages. In fact, for women with endometriosis with metabolically and immune dysregulated infertility, a 2022 animal study published in the journal Biomolecules discussed that there's now substantial evidence suggesting crosstalk between the reproductive gut axis. So we talked about this all the time, like the endocrine system and the gut microbiome talk to each other. There's this co-coordination. There's still a lot of question marks about the mechanisms linking metabolism with reproduction, but we know there's a clear link, and it's probably mediated by the gut microbiome or other microbiota in the system, like the uterine microbiome or the vulvovaginal microbiome, or all of these. That animal study evaluated the possible role of using GIPs or GLP-1s in reproductive function by examining the receptor distribution and the effects of global GIPR receptor and GLP-1 receptor deletion on estrous cycling, so that's like menstrual cycling in animals, and reproductive outcomes in mice. GIP receptors and GLP-1 receptor gene expression were readily detected by PCR in female reproductive tissue, including pituitary, ovaries, and uterine horn. So for women who are taking Ozempic or other GLP-1 agonists, and there are GIP drugs coming out on the market as well, that's in kind of final stages of research, so keep looking for that. We know the receptors for those GLP-1 peptides are in pituitary, in the brain, in the ovaries, in the uterine horn. So these drugs are not just impacting weight loss, they're impacting the inflammation associated with these various tissues. And to me, that's great. This is promising. We now have some tools to support the deficiencies that women with endometriosis are expressing in these areas where they need these peptides. And that's what these drugs really are. These drugs are a form of the peptides that have been studied for, anti-inflammatory and diabetes for more than 20 years. So while I don't believe that taking GLP-1 agonists like Ozempic is like a one-size-fits-all cure and helps with metabolic health for women with endometriosis immediately through perimenopause, I do think there's an important role for kind of supporting the deficiency that we now know that women have in GLP-1 peptides. So functional studies in these mice basically revealed that the female mice that did not have that kind of lacked, or they were lacking that GLP-1 receptor and the GIP receptor, they had significantly dysregulated estrus or menstrual cycling compared to the control mice. And that indicated their reduced fertility. Treatment. So in this study, they treated these mice with the GLP deficiencies in the receptor and the GIP receptor deficiencies with oral metformin. This is normally used to help with PCOS fertility. And they did find no amelioration of pregnancy outcome, except the litter size was approximately 2 times greater in the second breeding cycle for those that were lacking those receptors. So this study, it is an animal study, but it really highlights the significance of incretin receptors, the receptors of these peptides that we now have access to as medications in modulation of female reproductive function, which may provide future targets for pharmacological interventions in reproductive disorders. And in 2023, an expert opinion was published in the Journal of Expert Review of Anti-Cancer Therapy called Research into the Use of GLP-1 Agonists for Obese Patients with Malignant Endometrial Pathology to improve fertility by reducing weight, decreasing inflammation, and decreasing insulin resistance. So while endometriosis is not cancer, it is a chronic condition that does impact the health of the endometrial lining and can increase risk of certain reproductive cancers. And women with endometriosis, we do know, struggle with increasing inflammation, challenges with insulin resistance. And so thus, this tool could be very, very useful, GLP-1s, for fertility in this population, even if it has not become cancerous. And look, this research is urgent because actually more women of reproductive age are now beginning to express malignancies or cancers of the endometrial lining. Another study kind of supporting this use of GLP-1 agonists in women with fertility challenges is women with PCOS with fertility challenges. In a 2023 meta-analysis and systemic review, this was published in the journal BMC Endocrine Disorders on the effects of GLP-1 receptor agonists on pregnancy rate and improving of the menstrual cyclicity. So women with PCOS tend to have longer menstrual cycles, not as consistent, short, regular length menstrual cycles. So in this study, there was a total of 840 patients, 469 individuals in the GLP-1 receptor agonist group, and 371 in the control group. There were 11 randomized controlled trials included in this meta-analysis and systemic review. The GLP-1 receptor agonist usage was associated with improvements in natural pregnancy rate and menstrual regularity across women with PCOS. There was no significant differences in total pregnancy rate, IVF pregnancy rate between the two groups, but total pregnancy rate elevated in a short time after the GLP-1s in the subgroup analysis. Randomization to GLP-1 receptor agonists, these drugs, this treatment was associated with a greater improvement in insulin resistance, BMI, waist circumference, sex hormone binding globulin, and a slight reduction in total testosterone, which again could be good or bad depending on your client's issue, compared to the control group. And in the European population that was studied in this, there was seen a decrease in total body fat in those using the GLP-1 receptor agonist. So their conclusion was that prescription of GLP-1 receptor agonists improves natural pregnancy rate, menstrual cyclicity, and insulin sensitivity, atheropermetric, so waist to hip ratio, and hormonal indexes in women with PCOS. So while the research that we just discussed, this body of research, well, actually, before I get into this, I want to sort of summarize. Okay, GLP-1 agonist. So let's talk about what we've talked about so far. Women with endometriosis specifically, and other chronic diseases in general, should not be excluded from medical hormone therapies because of their underlying chronic condition. However, these hormone therapies need to be used carefully in an environment where we've done everything we can to optimize digestive function, detoxification function, immune function, gut microbiome health, nervous system function. We have tons of lifestyle medicine, nutrition, supplemental tools to help those systems work optimally, so that if we layer on a little bit of supportive hormone therapy and used in a specific way, that can reduce risk without increasing side effects. And the same thing, I believe, we're going to see more and more for women with endometriosis who are perimenopausal, 40s, late 40s, mid 40s, and want to have children, or even 30s, because don't forget, perimenopause begins as early as age 35 or so. We can support fertility from a metabolic standpoint using GLP-1 receptor agonist medications. However, oftentimes the pharmaceutically available medications are at a very high dose, too high of a dose, and can incite a lot of side effects. There are low dose compounded options of these peptides that have been used for years in, naturopathic medicine, in sort of quote unquote alternative medicine, even integrative medical communities, to support metabolic health at that cellular level. And this is where I think we need to begin. Unless your client really has true obesity, type 2 diabetes, then those relatively higher doses that are available, just in general pharmaceutical prescriptions, may be the place to begin. But for our clients who get all the support around strength training, walking, sleep hygiene, social connections, anti-inflammatory nutrition, nutrient-dense nutrition, antioxidant nutrition, hydration, detoxification support, lowering the toxic load, cleaning up chronic infections. We get the kind of the foundation nice and clean, no matter what the quote unquote diagnosis or genetic vulnerability exists. Then these tools can be super, super valuable hormone therapies and GLP-1 peptides in very, very low doses to start and possibly to stay. So I'm very encouraged by this, because I think women with endometriosis are often sort of left out to dry when it comes to that perimenopausal transition, without thinking about how to integrate these more complex, more cutting edge tools with the lifestyle strategies that we know set a good foundation. But many women will tell you they did all the right things, right? They ate really well. In fact, some of it can become too perfectionistic if we leave it to only lifestyle changes, only nutrition as being the only options, right? They have to be perfect at their sugar-free, gluten-free, grain-free, dairy-free, right? It ends up becoming a path to an eating disorder potentially. We do want a nice, clean, anti-inflammatory, nutrient-dense diet, but it doesn't have to be perfectionistic if there's a little boost of metabolic support. Sometimes it's enough to use supplements like berberine or chromium or cinnamon, but sometimes people need a little more support as they lose the estrogenic support. And so we do also have research that GLP-1 receptor agonists combined with estrogen therapy is even more beneficial for women. So moving into perimenopause, that neuroinflammation, that chronic joint pain, the pelvic pain of endometriosis, bladder pain, many of these symptoms, sleep irregularities, can be influenced by metabolic dysregulation. So working with a team like ours that utilizes that completely integrative approach, where we're going to help you with the nutrition and lifestyle and actually how to integrate it in your life without it becoming an overwhelming full-time job, but also supporting the body in this in the environment that we live in, which is very high stress, very high toxin, more and more infectious agents that we're exposed to by the day. So, let's get our bodies even more resilient through this transition and use the tools that we have. One last issue I want to talk about before we wrap up our protocol is, while the research we just discussed on the metabolic markers that were studied in those with endometriosis, this particular research study did not find a general increase in PAI1 deficiency, also known as SERPINE1 deficiency, for people with endometriosis. But a study published in 2018 in the journal Biology of Reproduction analyzed the role of PAI1, which is otherwise known as plasminogen activator inhibitor 1, in endometriotic lesion growth. These researchers studied the effects of PAI1 inhibition by using a mouse model of endometriosis that allows non-invasive monitoring. The endometrial tissue from the donor mice was collected and labeled with an adenovirus and then implanted into a subcutaneous pocket on the ventral abdomen of the recipient mice. 7 days after transplantation, the mice were randomly allocated to 2 groups and treated once daily for 2 weeks with either control or a PAI1 inhibitor. The endometriotic lesion size that was generated in the recipient mice was then monitored by that signaling. Animals were then euthanized after 21 days, and scientists were able to look for the endometriotic lesions and look at the fibrin within those lesions, look at the vascularization, the collagen content, to see what do these lesions look like from a fibrin. And kind of if you think about the fibrin is that growth of connective tissue. In women with endometriosis, they'll often say, I have adhesions. If you're looking at people that have chronic viral syndromes, they'll have a lot of microclots or chronic infections that are hiding in biofilms. So it's this connective tissue-like stuff that keeps things kind of tied up in the system. And it can express in a number of different ways depending on what's going on. But in endometriosis, essentially they're looking at endometriotic lesions that are more fibrotic and there are more adhesions. So basically, when the mice lacked the PAI1 inhibition, there was more of that fibrin, more neovascularization, they didn't see a change in the density of collagen, but it was more fibrotic. Also, the lesion size could be increased due to that increase in vascularization, because the body is trying to sort of feed with vascular system the areas that maybe there's more microclotting, otherwise it's just that it's fibrotic. So this is important because even though this is not found generally in people with endometriosis, I've been doing nutrigenomic studies for our clients with endometriosis for a long time now. And it's very common for my clients with endometriosis or with a post-viral syndrome profile. And that could be Epstein-Barr, that could be flu, that could be COVID. It doesn't really matter. People with chronic viruses that hide in biofilms. So bladder pain is another key place to look for this. They often have genetic SNPs around PAI1 or SERPINE1. It's the same thing. It just has 2 different names. And so they need to eat and have more enzymes to break down this fibrotic tissue, these biofilms, these microclots. This is why things like serrapeptase are so valuable in women with endometriosis, or lumbrokinase is now being studied in long COVID. Just more enzyme-dense foods, kiwi and papaya and pineapple, and digestive enzymes are so valuable. And Wobenzyme, we use all these different kinds of enzymatic tools. And I think the reason that this is so important in the transition from perimenopause to menopause is if someone has these PAI1 or SERPINE SNPs and they are more clotty, more fibrotic, have more adhesions, estrogen can make that worse. And that's problematic. So we have to be really careful about the dosing of the estrogen. And especially we have to be supporting this with an adding more enzymes, whether it's through nutrition or supplements. It's something to really keep in mind. Now, there are not only risks of adding supplemental estrogen, but there are important risks of GLP-1 receptor agonist medications, which is why, again, it's so important to start at the lowest possible dose and with the fewest, in a compounded way when possible, so that you're not adding other things for the body to be sensitive to. Some of these risks of GLP-1 receptor agonists include disordered eating risks. So especially for clients that are already really, really restricting, we have to be careful of disordered eating, nausea, vomiting, diarrhea, thyroid cancer, pancreatitis, intestinal obstruction, loss of appetite, dizziness, mild tachycardia, headaches, indigestion, and sudden kidney diseases. Now, some of these side effects are pretty severe, so we want to keep an eye on them. And this is why is anyone using these medications, I strongly discourage you from just ordering them online willy-nilly, or, working with your kind of local, there's a lot of kind of wellness gyms that are just offering Ozempic pens, like NO. This is not a good idea. It needs to be looked at with a skilled licensed practitioner who works with a population of people with endometriosis and perimenopause. This is not something to do just randomly. You have to be mindful. Some of these are very serious risks. Now, there are also some very important side benefits of these tools, especially the low dose GLP-1 receptor agonists: improvement in cardiac tissue and function, reduced cholesterol and blood pressure, stimulation of the vascular endothelium to produce more nitric oxide, reduce oxidative stress, and reduce atherosclerosis. Also, anti-inflammatory effects throughout, from the brain to the joints to the cardiovascular system. Studies have shown positive impacts on kidney outcomes in patients with type 2 diabetes. And as I said, glucagon, like peptide 1, GLP-1s, suppress neuroinflammation and improve neural structure. So these medications and these tools are not to be taken lightly. This is why we have a skilled, licensed medical provider on our team who's going to work with us in collaboration with the lifestyle strategies to do this with the absolute most benefit and least risk from a client by client perspective. This is not a one size fits all strategy. And before we wrap up this podcast episode that I hope is blowing your mind, I really do, I have one more point to circle back on regarding the biomarkers. When we talked about the PAI ones, we really have to be supporting using the enzymes, using the liver support, and this issue of increased fibrosis and clotting risk, because it can be exacerbated by estrogen. We have to be focusing on that foundation first. So whether your client or you will benefit from a low dose of GLP-1 agonist or a hormone supplemental therapy or combination of therapies, estrogen, progesterone, testosterone, it always has to be in the context of that healthy lifestyle, anti-inflammatory nutrition, anti-inflammatory lifestyle, connections, social support, movement, and considering things like mast cell activation, which can be exacerbated by estrogen, post-exertional symptom exacerbation if we're dealing with endometriosis and a chronic post-viral syndrome. How much can we exercise? What are the metabolic impacts of that? What are people tending to be sensitive to from an inflammatory perspective? So none of these tools can be utilized in just kind of a simple protocol way. We really have to set those foundations and then wrap up our coaching protocol by creating these changes in lifestyle, changes in breakfast and morning routine and sunlight and nature exposure, in how people are adding strength, because Sometimes GLP-1s also can contribute to muscle loss unless someone is strength training. So these foundational lifestyle changes, none of our clients, none of us can do all of them overnight. So in step 5, we create 1 week, 1 month at a time, integrated transformational lifestyle changes that are well supported in step 6 by the entire web of support. So we go at the pace that the client can handle. Maybe she has little kids. Maybe she's got a really busy job. Maybe she's caring for a sick family member. Women in ages 35 to 65 have a ton on their plates. So this is not a quick 1 month, fix it all. But a lot can happen with slow paced transformational change. And if we use the support, if we use the coaching model, and we continuously in step 7, balance and reassess where we are, celebrating how far we've come, celebrating the vision, where we are in that vision, what we want to change about the vision, what the client's goals are around health. This is a sustainable strategy that can be used from age 35 to age 100 plus, because we're always centering what is the client's health goal now and a little bit in the future, being open to that flexibility. What support do they need to live the life that they actually want? And in perimenopause and menopause, there's no exception. It's just sometimes a bit more complicated as women lose that support, that beneficial support of estrogen, which is so complicated in that environment of the underlying endometriosis or other complex chronic illness. So if we just simplify it, do everything we can to optimize foundational health, and then use the tools we now have access to with supplemental hormones and peptides in a way that is very thoughtful regarding the individual risks and goals. I mean, I really see us being able to support women and their health goals well into their hundreds. Like, they can be dancing, they can be present with children, grandchildren, great grandchildren, they can be traveling, they can run businesses when they're 60, 70, 80. The sky's really the limit as long as we're patient and implementing at the pace that feels really aligned and supported for each client. So I hope that the 15 research papers we just dove into were really exciting to you. I'll list them all in the show notes. If you would like to work with us in our practice, as I said, we now have a medical provider who can help us really specifically fine-tune these prescriptive recommendations for you. Just simply reach out to support at Integrative Women's Health Institute.com. And we'll be announcing our group program for helping people transition through perimenopause and menopause with endometriosis or any other complex chronic illness. We are here for the complexity. We are not afraid of it. This is what I've been doing for 25 years now. And, I'm excited about this because I think there are very few places in our conventional medical system and even in our integrative medical system where complexity for women navigating perimenopause and menopause, there's a safe space for that. We're here, if you're struggling with histamine stuff, if you have dysautonomia, if you have bladder pain, if you have gut dysbiosis, this is what we've seen and been doing for years and decades. So we'll help you navigate that perimenopause and menopause transition with the most vibrant health. I've been seeing women in their 40s, 50s, 60s, 70s, and beyond really have healthy, thriving health, no matter how much they felt like their bodies were just like falling apart and going haywire before they came in to work with us. So I'm really ready to scale this up and see lots and lots of women doing absolutely whatever the heck they want with as much energy and as much health as they want well into their 60s, 70s, 80s, and beyond. So I'll see you next time on the Integrative Women's Health podcast. Reach out to our team at support@integrativewomenshealthinstitute.com. And if you want to learn how to do this for your practice, follow us at integrativewomenshealth.com, where you can see all of our professional level training courses, and follow us on Instagram at Integrative Women's Health. Please press follow on this podcast. The more people following the podcast, the more exciting guests I can bring you. All right. See you next week. Bye.